So good evening, all of you. Welcome to the 89th edition on this very practical aspect topic, assessing cognitive deficits in elderly persons. The housekeeping rules are simple. Everyone is on the mute mode. The questions can be put in the chat box. The meeting is recorded and will be available on our Facebook page. Next slide, please. Let me hand over the meeting to Professor Dr. Tufan Pati sir from Cuttack. He is the organizing chairperson and the backbone of the program. Sir, over to you.
Thank you, Aleem, and thank everybody who have joined here. And over to the next slide. Just a glimpse of our vibrant moderators, Dr. Amrit Patjoshi and Dr. Aleem Siddiqui. Next slide, please. We are skipping our introduction to be close to the speaker. Next slide, please. Our chairperson, Dr. R. Satyanathan, is currently running a memory clinic in Anna Nagar and is the senior consultant psychiatrist. He is an eminent psychiatrist in Tamil Nadu. Previously worked under Professor and HOD and senior consultant psychiatrist R. Sri Ramchandra Medical University, Porur. He also headed the geriatric care clinic R. Sri Ramchandra Medical Center, Porur, Chennai. Dr. R. Satyanathan served as the Director of Mental Health in the government of Tamil Nadu prior to the current place. He obtained a master's degree in psychiatry from reputed Madras University and his master's in public health from University of North Carolina, Chapel Hill, USA. He is a visionary who advocates development in the area of mental health in the country. As a director, Clinical Epidemiology Unit, MMCMGH, Chennai. He has hands-on experience in organizing and coordinating several national and international multi-subject research projects and leading research teams. With this, I welcome Dr. R. Satyanathan. Welcome, sir. Next slide, please. Our other chairperson is young, dynamic Dr. Sabina Rao. October 7, 2017 to present, he is consultant Manipal Hospital, Sharjapur Road. After October 2015 till present, she is consultant Annaswamy Mudaliar General Hospital, Pulakesh Nagar, Bangalore. And she is also consultant Department of Psychiatry, Sakra Wall Hospital, Outer Ring Road. Psychiatrician consultant for the Emotional Wellbeing Program for Elderly, Kites Health Clinic, HSR Mayhow. National Institute of Mental Health Neurosciences, Bangalore, India. She worked there from 2012 to 2015 as a psychiatrist, specialist grade in Chakalawara Community Mental Health Center. Annaswamy Mudaliar General Hospital, Bangalore, India. She worked from 2011 to 2012. She has received the Richmond Fellowship from 2011 to 12. Lundbeck, India, January 2012 to June 2012, medical consultant for the Danish Pharmaceutical. John Armstead Hospital, Central Regional Hospital, Bernard, North Carolina, USA. 2007 to May 2011. National Institute of Mental Health and Neuroscience, Bangalore, April to May 2012. So versatile, widespread experience. We have got young, dynamic, and equally vibrant Dr. Sabina Rao. With this small introduction of our esteemed chairperson, I hand over the proceedings, further proceedings of the meeting to Dr. Sabina Rao and Dr. Satyanathan. One of the chairperson has to introduce our speaker, and the CV will be displayed by the support staff, and the other chairperson will introduce the topic. So over to the chairpersons, please. I think Dr. Sabina Rao will introduce the topic, the chairperson speaker.
So,
can introduce chairperson, ma'am.
It's my great pleasure to introduce Dr. Debanjan Banerjee, who did his MD, DNBA, and his fellowship in geriatric psychiatry from NIMHANS, Bangalore. He's a consultant geriatric psychiatrist currently in Apollo Multispeciality Hospitals, Kolkata. He has clearly a very varied interest in research, human rights in older people, dignity in mental health care, social psychiatry, misinformation, psychosexual health, palliative care. He's a deputy editor in chief of Journal of Psychosexual Health, associate editor, Journal of Alzheimer's Disease, and assistant editorial editor of the Indian Journal of Social Psychiatry. He's also a co-chair, advocacy and public health awareness committee member, International Psychogeriatric Association, IPA. He was a convener, early career psychiatry subcommittee, SARC Psychiatric Federation. He has 100 plus index publication, 16 chapters in national, international journals, and he is a columnist for several public outreach programs and publications. Welcome, Dr. Banerjee. It's very nice to have you here, and we look forward to hearing you give us a good overview on the topic today. Dr. Satyanathan?
I request Dr. Satyanathan to please.
Yeah. Good evening.
Topic.
Good evening, every one of you.
And Shreya, can you stop sharing the screen?
You are able to hear me?
Yeah, we can hear you.
Yeah. So thank you very much. I would like to thank the co-chair, Dr. Sabina Rao, and the speaker, Dr. Banerjee, and of course, Dr. Topan, and then Dr. Amrit and Dr. Alim Siddhi, who invited me for this meeting. It's a very important and very crucial thing, assessing cognitive deficits in older people. The real problem I will have a briefly talk about it in 5 minutes. The real problem in India is that many of the elderly who develop cognitive deficits are not picked up at the early stage because they think forgetting is part of aging. That is what has been happening. This is what we have been telling 30 years back. Even now we are telling, because many of these people are brought to us only at a very late stage when the cognitive deficits have become very severe and then they become disabled. That's the time people think. The reason is we failed to pick up. And then I met Dr. in a national hospital in London, and then what they said was, what we need in India is that more than psychiatrists, we need to train general practitioners to pick up early memory disturbances in elderly people, because most of the elderly people, either they go to a general practitioner or they go to a cardiologist or a neurologist, nephrologist, and then before they come to us. So early sign of a memory disturbance must be picked up only by these people. We need to train them. I think the whole idea is that how to assess this function. Of course, we can talk about, we are now talking about preclinical Alzheimer's, and then because the process of the Alzheimer's starts even 15 to 20 years before the illness starts. So it is very early that we need to identify those elderly people who have got a mild cognitive impairment. We know that not everyone who has got a mild cognitive impairment ultimately develop dementia, but we need to screen those people. So every district hospital should possibly have a geriatric unit, and anyone who comes for any elderly person going for some other specialty must be seen in this geriatric clinic. And it is very, very important that we need to have a memory clinic. We need not have a very well-fledged memory clinic, but we need something like probably that is what Banerjee will tell us about, how to pick up early cognitive problems in elderly. Before we think in terms of biomarkers or neuroimaging or genetic testing and all these things, that what should be trained reasonably well to assess not only the memory, but also the verbal ability, and then the ability to do numerical testing, able to abstract reasoning, executive functions, problem solving, critical thinking, and strategic thinking. These are the things must be picked up and all these things. And of course, there are a lot of scales. We generally talk about Minicog, MMSE, and CAMDEX, and these are the tests that can be administered within 10, 15 to 20 days. And nowadays, we have been using a lot of MoCA, what you call a Montreal Cognitive Assessment Scales and all these things. But Minicog is better because you give clock drawings test and then 3-item recall test and all these things. So it's very, very important that we need to assess cognitive functions in elderly people, even at the age of 50, 55 years, like we do a master health checkup. So when they come for a master health checkup, they also need to be screened for cognitive deficits. So ultimately, we are able to identify those people who are possibly at a risk and then should be naturally followed up. We know because any cognitive deficit in elderly, if you identify them early, it is always the treatment becomes more beneficial than at a time of chronic. When they become chronically disabled, they become a burden to themselves, they become a caregiver, become burden and all these things. And ultimately, it is on the economy of the society and the country and all these things. So in this context, I feel this Thursday Musings has identified a very, very, very important topic about assessing cognition deficits in elderly and all these things. So I'm very happy that Banerjee is there, and then he will be telling us about the cognitive deficits in older persons, how and a clinical primary. It is not predominantly psychological testing what we have to do. So I'm very happy that I've been here, and then I request Dr. Banerjee to go ahead and then make his presentation. If unless my co-chair wants to make some statement or a top and party wants to say something or Alan Siddiq want to say.
I think we're good to go, sir.
Yeah, okay.
Yeah, I'm audible, right? Yeah. So thank you so much, Dr. Satyanathan, sir. I think it's an honor to have you share this session today. And Dr. Sabina, ma'am, it's good to see somebody back from my NIMHANS days again. So very good evening to everyone. And I sincerely thank the Thursday Musings team for giving me this opportunity to be here today to discuss something which, as Sir mentioned, is extremely relevant, not only for psychiatrists, but I believe for all the clinical specialties, and especially for the primary caregivers, because they will be receiving the maximum brunt of these individuals with cognitive deficits. So I'll be sharing my screen now. The slides are moving, right?
Yes, good.
Yeah, thanks. So just feel free to interrupt me if anytime you feel that my voice is, not being heard or there's any glitch in the screen presentations. So what I'll be doing today over the next, 40-45 minutes or so is take you through the very basics of cognitive assessment in older persons. Now, mind it, I have highlighted the clinical primer, and as Sir also mentioned in the introduction, that this is mainly about understanding clinically as well as supplemented by some structured and unstructured assessments. Not to go too deep into the theoretical aspects of it, but I do hope and I believe that at the end of this presentation, I'll be able to give you an overview. So it doesn't matter in which setting you are practicing in, but if any older adult visits you in whom you suspect a cognitive deficit, you'll be able to assess meaningfully and also prognosticate the person as necessary. So to start off at the outset, I should declare that I have no disclosures. And as I move on, this will be kind of the pattern. We'll look into briefly what cognition really means. And when we are assessing cognition, what are we really assessing? So it's not just about memory, it's much more. Going into the clinical aspects of detecting early signs of cognitive deficits, following through with structured assessments of cognition, the associated structured assessments. So when we are assessing the cognition, we are not just assessing memory and other related cognitive domains, but we are also assessing the functionality of a person, the behavioral and psychological symptoms of dementia, the everyday activities that the person is doing, apathy, and so on. And finally, we'll go to understand that if we are assessing a bit focused, lobes or the very early lobar signs, yet very basic bedside testing of the different brain lobes, and we'll be ending with what challenges do we commonly face in this entire process, especially remembering that we are in India today, which not only has a rapid population aging, but an increased burden of individuals living with dementia, and finally has multilinguistic challenges in cognitive assessment. So when we talk about aging and when we talk about cognitive deficits, it's a continuum. a person doesn't wake up one day and age, or, the cognitive deficits in whatever domains it is, doesn't come just one fine day. So there will be the impact of frailty, of sensory loss, of cognitive reserve, of how much a person involves in cognitive activities, and that will be having a bearing on what you assess. So what is the relevance of this slide here? When we are assessing cognition as clinicians, we shouldn't forget that these things need to be in place before I can really proceed with testing the cognitive domains. So I need to be careful about the context, the social background of the individual, family, fear, whether the person is suffering from depression, anxiety, whether a language matches, so on and so forth. We'll not be going in too much into the depths of the theoretical underpinnings of dementia, MCI, types of dementia, and so on. That needs a separate discussion altogether. So today we'll stay focused on just very clinical aspects of the assessment. Now, we know that when cognitive deficits start appearing, they appear on a continuum, and this may progress or may stay stable with time. As Dr. Satyanathan was mentioning right in the beginning, that the pre-dementia stage kind of starts, let's say, around 15, 20 years before, and now there are various other means to detect. But just to give you a message, friends and colleagues, that it is never too early and never too late to start assessment of cognitive deficits if you really suspect. And this index of clinical suspicion should be high in individuals who have medical comorbidities like diabetes, hypertension, ischemic heart disease, cerebrovascular accident or strokes, has chronic pain, is in loneliness, social isolation, recurrent depression, is not having sufficient amount of social stimulation, and so on. So for them, the index of suspicion automatically gets high, that when you will be testing for cognitive impairment. And when you test for cognitive impairment, of course, it is important to understand that what we'll be discussing today is not how to diagnose dementia. That is different. So we use clinical criteria for ICD or DSM. DSM is now, it's more geared towards major and minor neurocognitive disorders. So that is different. We use clinical criteria and maybe, other stuff in drug trials to substantiate dementia. But assessing cognitive deficits is not in its own accord enough to satisfy that a person is having dementia. So we can have this discussion later if time permits. But as you know, any diagnostic criteria has to have corroboration from both the family and the individual, and supplemented. So either from the family or from the individual, and supplemented by a structured cognitive assessment. So then we can diagnose dementia. Now, again, we'll see that a lot of modifiable factors can influence cognitive functioning. Hence, the moment you're getting any cognitive deficits, I think it's important to take a step back and see and review all these conditions before coming to the conclusion that these cognitive deficits are reversible or irreversible. Finally, coming to today's discussion, what do we test? What do we really mean by cognition? For decades, the research of dementia and Alzheimer's have been excessively clouded by memory. In fact, if you even look at the DSM-4 criteria, it has an immense stress on memory being the primary domain. However, with emergence of further research and with other types of dementia, again, when we are discussing today about cognitive deficits, even though many of you may feel that it is more focused and geared towards Alzheimer's disease, this is not towards any specific form of dementia, be it Alzheimer's or non-Alzheimer's group. But what we test is, we test different aspects. So we test attention, which is complex attention in DSM-5. We test language, we test memory and learning, we test visuo-perceptual abilities, frontal abilities like processing, that is social cognition. And also finally, you have to test for whether intelligence or cognitive deficits have been pre-existing. So let's say somebody has a viral encephalitis, somebody has IDD, intellectual disability disorder, somebody has post-neurodevelopmental delay problems. So how much of deficit you are truly seeing will be dependent on what has been the medical history and the pre-existing cognitive status. And here is where the importance of cognitive development comes, that, there are abilities that a person gains throughout his or her life, and it is not necessarily a static process. So as I mentioned, that it is never too early and never too late to really test for cognitive deficits if you really have an index of suspicion. Now, what are the factors which can influence cognition? So when you are going to test someone, right before that, I think we should have our antenna straight and we should think about what are the probable factors which can influence what I'm going to test today, which can potentially bias a cross-sectional assessment that I'm going to have with an older individual over the next, let's say, if it is very brief or even if it is structured like a battery for the next 2 hours. Frailty, that is the cumulative biological vulnerability. The mood state, if the person is just unmotivated, apathetic, not wanting to do stuff. If the person is under intoxication, what is the sensory status? So many times I have started my testing in my residency days and then realized that the gentleman was either not able to hear or, some lady was not able to see the test properly. So, you have to really reboot and restart again. Whether the person is taking multiple medicines, somebody takes benzo and comes to your clinic, somebody takes TCAs, somebody takes a mixture of multiple medicines, they have hypoglycemia early in the morning waiting in front of your clinic. All these are viable factors which can actually influence their performance on that particular day. Whether the person is coming from an old age home or assisted living facility, what was the degree of social impairment, social deprivation, what was the degree of lack of independence and autonomy, especially post-COVID, post-lockdown, when many older individuals came to us. This was a very important factor. If the individual is actually in pain, many people with osteoarthritis, they will find it very difficult to sit for prolonged time. So their focus, their attention is not really if you are testing. That will also give biased results. What is the context of assessment? I'll come to this later. And as Dr. Satyanathan mentioned right in the beginning, that there are several challenges when we conduct tests in the Indian scenario. To give you a very rough example, many people, when they come to your clinic, they are not expecting that you will sit with them and you will give them a pen and paper and you will tell them either to copy some figures or name some things. So it comes out of the box, out of the blue. And that often biases the results that we have. Familiarity with the cognitive assessment tools used. So if a person has undergone HMSC or Minicog multiple number of times, you can actually learn certain kind of responses. And finally, whether the tools that you are using have enough socio-cultural sensitivity. And that's why different tools have been validated in different languages. What are the domains that we assess? We have already discussed this. And, these are the other subdomains under each of these larger domains that we assess. I'll not spend too much time here because, again, this is not the core topic of discussion. The associated domains. So today, when we discuss how do we assess cognitive deficits, we'll also be discussing the severity, the functional impairment, caregiver burden, the activities of daily living, and finally, BPSD. So coming to the first and foremost important thing, throughout our training, be it in psychiatry or, in geriatric psychiatry, and I'm sure my teachers will agree with this, it's always been emphasized that as a clinician, even if you are in a clinic and you can allot 15 minutes to every single individual, and even if it's a memory clinic, the first assessment starts when you see the person first, even if it is in the corridor. So there are certain things which you can pick up even before you do any HMSC, any Minicog, any skills. And these shouldn't be missed. And these probably in a routine clinical practice serve as the gold standard for assessing cognitive deficits. So very quick observation. What are the things do you normally see? Whether the person is confused, whether the person is delirious for any reason. So if somebody is in delirium, you will of course take some other measures to assess. You will not really go into a core cognitive assessment because there is no point. Whether there is a socially appropriate behavior when you communicate with the person and the person communicates with his or her family member, whether the verbal and non-verbal communication is good enough. Expressive speech, when the person is talking to you, the person walks to your chamber, is the person able to navigate or, goes towards some other side, not where the person is supposed to sit. If somebody has spectacles, somebody has hearing aids, whether they are wearing it, whether they have it with them, what is their reaction towards you, and very, very simply we'll be able to understand praxis with the motor movements that the person has. Also, sometimes, though rare, you can see hemi-neglect, and you'll be able to see that even for shaking hands or for movements or for writing, the person will totally be using only one side. So these are the things which you can observe and you can always note them down. So it's documentation forms a very important part of assessing cognitive deficits, because it's not only important for, let's say, medical legal purpose, but it's also important for you to have a baseline and then prognosticate, because things can change very subtly and very suddenly also if it is not, a typical dementia. Let's say you assess somebody with DLBD. So there will be fluctuating, sensorium, and you can get different times of the day, different results. Let's revisit some of the basics. So many of you may think that these are extremely, common. We all know this, but trust me, I can vouch for myself personally. These are the things at which I falter even in my day-to-day clinical practice. So these are certain things which are, which are very basic, but which are nuanced, and you can actually get them while you talk to the person, talk to the individual. So how do you, in terms of recent episodic memory, difficulty in remembering conversations, asks you the same question again and again, forgets the dates, forgets, what is the date today, and let's say when was the appointment, forgetting to pay bills, and, if the person has to keep the, let's say, the mobile or any bag or any purse, you can actually understand if there is a problem in the visual depth perception, if the person is misplacing or losing the belonging, even in the time that, the person is there in your chamber. Remote memory. And we all know, certain things, certain though autobiographical memory is a bit different from remote memory, but more or less some things which have happened years back. Attention and concentration. Well, simple communication, or you tell the person to do something. So whether you can catch the person's attention, simply with a thing like this or with a wink, and the person responds to you. Something that we even do as a part of our, mea gros. And also whether when you are giving the task to a person, if the person is able to respond to the task in a meaningful manner, at least understand. Language, which has a varied aspect to it. It's not just speaking, but the grammar, the syntax, the linguistics, the ability to express, the ability to comprehend, read, write, all of these. So how do you understand when you speak to a person? Does the person have difficulty finding words? Instead of a watch, whether the person tells, this is something in which I look at time, or whether the person has semantics, so substitutes one term for other, semantic paraphasia. Does a person give tangential responses? Does a person stutter? Is a person anxious? Does the person, can the person name common objects? Now, again, here, even though time may not permit, but we will be happy to discuss later on, there is difference between if the person is able to name common objects versus if the person is able to name familiar faces, because these two, again, are functions of different parts of the brain. But again, when we discuss this here, this is not really to pinpoint the lesion, but more to understand in a very busy clinical setting, to pick up quick signs of a person who is having cognitive deficits. Now here I should actually mention something which is very important. The cognitive reserve, the degree of education and the job of a person has a lot to do with you picking up the cognitive deficits. Imagine someone who has ran a shop for multiple times, for multiple months, years, and then one fine day he has problem in calculating. Somebody who has been in a CEO and a very busy person, and one fine day he has, suddenly difficulty to book his cab, use an app-based taxi service. Somebody who has been a farmer, has regularly taken care of his bullocks, but one fine day has problems finding or feeding them. So in different cultural contexts, how the cognitive deficits are picked up will depend on the degree of functionality of that individual. We have to remember again that we are in India. Many cultures consider old age to be a relaxing period. So even, even if we say about healthy aging, physical activity and stuff, many times you are not expected to do the work that you were doing before, or you have multiple helpers, or people are going and doing it for you. So even if a person is having mild cognitive impairment, they may not surface unless they are really expected to do something. But language is something which will of course manifest. So let's say in things like semantic dementia or in PNFA, these can come up very soon, and hence grammar, syntax, and expressive speech are extremely important. Praxis, when the person comes to you, does the person have difficulty in using familiar objects? I'll come to praxis later again. Do you get a history that a person has problem in dressing correctly, the common button, unbutton thing that we do? Many times you will see that the person is unkempt. If you ask, you will see that, there is no caregiver and the person is unable to shave. Same goes for the hair. And also the things that will be there in your chamber, as simple as a pen, if the person is unable to use it. Perceptual skills, difficulty in finding the chair to sit, difficulty in navigating inside and outside your chamber, problems in changing the watch, problems in recognizing familiar faces. And executive functions, which again is a frontal function and something which is detected very early. Problem in multitasking, problem in using app or mobile, which has been very common before. Maintaining the household activities, paying the bills, going for bank. Many times difficulties in IADL, that is instrumental activities of daily living, can lead to understanding that the person is having executive dysfunction. A common thing that we often ask, if the person is, working in the kitchen or is used to doing that, is what are the steps of making tea or coffee? And that often is jumbled for that person. And finally, the frontal behavior, apathy, less interested, amotivation, socially inappropriate behavior and stuff. So coming to structured assessments, on which we'll probably be spending a significant amount of time, because again, I'll take my personal example and the feedback that I've got from my friends. This is an area which at least I was not, very confident of when I completed my, MD psychiatry. But with practice and with use, at least in some clinical setting, I think it's really helpful, because a lot of persons whom you see are depression, dementia, overlap, or pseudo dementia, you can actually successfully understand the changes in treatment if you have some prognostication or some scale for use. We'll not go too deep into delirium, but this is just to keep you aware of the hierarchy that we do have. A person can very well have delirium per se, have delirium on dementia. Dementia is an independent factor for the risk of delirium. And finally, as I mentioned right in the beginning, can actually come to you in a delirious state right at the time of examination. So ideally, again, it's a clinical assessment, but the most commonly used scales are confusion assessment method. I'm sure many of you have used who have worked in the ICU settings, and also the delirium symptom interview. Again, this is not delirium tremens. So this is a delirium due to any other cause apart from alcohol. I will be showing multiple scales as I go through my talk. Don't worry if we are not able to cover each of them in detail. If any one of you wants to get in touch with me, I'll be sharing my mail ID, feel free, and I'll be sharing the scales with you, or we can have a discussion on them separately. This is again just for an overview and to familiarize you with all the scales that we commonly use. So confusion assessment method is the most used scale in any research with delirium or to ascertain delirium. And like our ICD criteria, it focuses on acute onset, inattention, perceptual disturbances, altered level of consciousness, and disorganized thinking. Mind it, if a person with dementia has presented to you in delirium, then you cannot use any structured assessment in him or her in the beginning. You have to wait for the person to go back to the basal cognitive state before you can really go ahead. These are the different screeners that we use. We'll be briefly looking at each of them. MMSE, HMSE, extremely common. The cognitive screening battery, which was developed by Ganguly et al. And which has been validated in India. In fact, I'll come to it later that HMSE is actually a part of the cognitive screening battery. The AD8 dementia screening interview, the GP-COG, IQ code. The GP-COG, IQ code, and mini-COG, they are very brief. So they can be used quickly in a matter of few minutes. Also the AMTS. So if you really find, sometimes in a busy setting, you may not have sufficient time for people to assess them in detail. So if you have a clinical suspicion, you quickly do one of the screening tests. And then if you actually catch something, you can go ahead into a detailed cognitive assessment. That's the usual protocol. More definitive, more in detail. So the MOCA, as Sir was mentioning in the beginning, the Addenbrooke's and revised Addenbrooke's, the ADAS-COG, which is commonly used in drug trials, the NIMHANS neuropsychological battery for the elderly, which we used to use, in our research and in people for whom, we in geriatric clinic who needed detailed assessment, and CAMCOG and CANTAB, which CANTAB is again the automated computerized version which takes the CAMCOG tests. Now, I haven't covered some of the skills like the PGI battery, the Kolkata cognitive scale, and so on. As per the topic, I'll stay focused and limited to assessments and the scales which are validated for older adults and also specifically for detecting neurocognitive impairment. Otherwise, the topic tends to become extremely broadened. So these are associated assessments which we'll be discussing: the dementia rating scale, the NPI, the everyday ability scale, and finally the IADL-E scale by Mathranath et al. These are the scales specially validated for the Indian settings. So for cognitive test, we have the CSB, the HMSE, the 1066. Many of you know about the study, which is a multi-nation 7-country studies, the Dementia Research Group test, the NNBE, MOCA, which has recently been validated, and ACE-R as well. For behavioral symptoms, we have the NPI and Behave-AD, and for activities of daily living, we have the EC and the IADL. Coming to each of the scales very briefly, this is AD8. As you see, it has 8 items, and usually a score of 2 or more is considered to be an indication of clinical impairment. The GP-COG, which is one of the most commonly used scales, especially in primary care settings, and that's the benefit. So this has 2 parts. One is the patient examination, when you basically test recall, orientation, clock drawing, and information processing, and also the feedback from informant. IQ code, which has 7 items for memory and 16 items for activities, instrumental activities of daily living. Remember, it is filled by the informant. And good thing is IQ code has a shorter version, which has 16 items. And of late, if you see literature, the shorter version of IQ code has actually stayed popular. The older version is almost obsolete in daily use. This is the shorter form of IQ code. So basically, you also have a question to the informant where you ask, how do you really see the decline? That's more of a qualitative response. It is not rated, but the question goes like, compared with 10 years ago, how is this person? Now, one of the criticisms of IQ code is that, again, it is heavily biased on memory, and other is it often leads to a recall bias in individuals were presenting to you quite later course of the illness. Coming to Minicog, most useful and the one which takes the least amount of time. It takes three important things. 3-word registration. This is the Western version. So the words which you see are actually, the Western version of it. The clock drawing test, and then the recall of the 3 words which you have registered after 3 repeated administrations. Many of you who have actually looked at the AVLT, which is also a part of our before ECT recode, that is the battery of NIMHANS which we use for detecting cognitive deficits post ECT. The AVLT test has this 3-word registration and recall component. That's not 3 words there, but the principle is same. And it basically captures your bit of your frontal lobe, temporal lobe, and also your visuoperceptual abilities, which is your parietal. That is why Minicog is considered to be a little bit more comprehensive among the brief scales used. And clock drawing test, in fact, has been, it has been argued and debated among different neuropsychologists that whether it alone stands the test of time as one of the very good tests, because it uses your visuoperceptual ability, your ability of orientation, your ability of working memory. So there are different methods of scoring, as you understand. It's quite complex. So this is the one which is commonly used by Shulman. There is also another by Sunderland. So it has a 6-point scoring system. And the common time that you tell the person to depict you first tell a person to depict a clock and then a rounded clock, and then you tell to depict 11 to 10. So that's what you commonly tell them. You commonly tell them 10 to 11. So, that's the time that is used in standard, but sometimes, other connotations of that are also used. The reason why we don't commonly use common times like 6 p.m. or 5:30 p.m. or 2 p.m. are that it also needs to have some degree of working memory. So a little bit complex time is needed. So that is why usually it is either 10 to 11 or, a time which is near to that. This is the scoring system by Sunderland. And just to give you an understanding, there are different types of error which can actually come in the clock drawing test. If you look at your left figure, you will see that there are visuospatial errors, there are disorganization of times, and also there are sometimes conceptual errors in which the minutes and the seconds clock or the numbers are not even depicted properly. And sometimes the clock itself is not drawn when the person's semantic ability is compromised. So what is a clock? The person may not be able to understand. EMTS is again a brief screening questionnaire. It is very biased towards the Western literature. So it has like items like present monarch and First World War date. The cutoff is 7 to 8. Coming to our very old and known MMSE. So it's brief. It takes time, it's very 10 to 15 minutes hardly. It does take into account registration, recall, language, and orientation. The common dictum is that the score of 24 or more indicates normal cognition. And also you can rate mild, moderate, severe based on this. And it can be corrected for educational attainment and age. However, and I'll come to this later, that taking 24 as a blind cutoff for cognitive deficits in Indian population can be extremely erroneous. The reason is that this is heavily biased towards orientation and memory. If you actually see, I'm sure all of you have come across MMSE, most of the questions will actually be about registration and orientation. So you are not really, apart from the intersecting pentagons, you are not really testing the visuoperceptual ability, you are not testing the frontal parts, you are not testing, you are not properly testing language or working memory. So if somebody has good linguistic skills, good education, and relatively preserved memory in early stages, as well as in non-Alzheimer's dementia, the person will not be sensitive enough to MMSE. This is how the HMSE was born. Now, many of you may have heard about this landmark study by Ganguly et al., the Indo-US cross-national dementia epidemiology study. And here the MMSE was converted into the Indian version of it. It basically compared two rural populations, the one in Ballabgarh near New Delhi, and the other comparative population in southwestern Pennsylvania from USA. The cognitive tools used were SERAD, logical memory test, clock drawing test, trail making test for processing speed and orientation. What is SERAD? Now, we'll come to this. We'll briefly discuss SERAD because again, this is a little bit complex battery. So it's consortium to establish registry for Alzheimer's disease devised by NIA, mainly for standardizing tests across all the Alzheimer's disease centers. It has a lot of different batteries for pathology, autopsy, imaging and stuff. Out of one is neuropsychological battery. It is geared towards Alzheimer's disease, verbal fluency, naming test, MMSE, which is incorporated in this, praxis, word recall, recognition are the components. Now, SERAD was actually taken and modified to become the cognitive screening battery. Now, as a part of the MMSE of SERAD, HMSE was formed. The object naming was changed. 2D models were changed to 3D models. The objects were changed based on Indian context. Verbal fluency was changed to fruits and animals rather than vegetables. Construction was changed to copying. The types of diagrams were changed based on the Indian literary context. And previously, the word list, you had to see them. But this time, it was auditory presentation. So you read out and then you repeat. You register and then you repeat. So these were the changes in the cognitive screening battery. Cognitive screening battery is still a very useful test which is validated in Indian context and is derived from the original SERAD. That was done by Ganguly et al. In the Ballabgarh study. If you compared MMSE and HMSE, you will see the type of the diagram has changed. Many of Indians are not very familiar with what a pentagon really means. Apple, table, penny were changed to mango, chair, coin. No ifs and buts were changed to neither this nor that. Close your eyes, a verbal command was changed to following what the examiner is doing. Serial subtraction, and this is very important. Rather than just giving a serial subtraction test, it was changed to a story. So you put a story, you put in a context. Bus is something which most of us use on a daily basis. But most of these tests have to be non-confrontational. So when you're doing the test, nodding your head or telling, okay, that's right, then say, or telling, no, that is not correct, try again. These responses are probably avoided. And also, if you see the HMSE contains the same components that the MMSE tries to test, but is heavily dependent on memory. So these are the significant limitations. It's not sensitive to mild dementia, and MCI depends a lot on age, language skills, educational level, has socio-cultural bias. And remember, very importantly, MMSE is copyrighted. So we did receive a notice one day in NIMHANS prior, because we were using MMSE in neurology, that how can this be used with an appropriate licensing, and then they led to a lot of discussion. So if you are using MMSE for your thesis, it's better always to take permission. They have relevant permission information, but it is licensed. However, HMSE is not. So that is the reason why we primarily use HMSE in our clinical settings. Also, it's not a great measure of working memory and executive functions. It's always better to test whether a particular test is, licensed or not. That will give us some understanding. The 1066 Dementia Research Group. Now, this was also developed from SERAD and the Community Screening Instrument for Dementia. The good thing is it has been normed and validated in 7 different countries, all of which come from the lower and the middle income countries. It's a good test for global cognition, verbal fluency, immediate and delayed recall, and constructional abilities. MOCA, which has become exceedingly popular now because it has been validated in India and it's brief, and it also has quite comprehensive testing, is sensitive to MCI, is not that sensitive to education, is a score of 26, is almost has a positive predictive value of 89%, and it is bit more easier to administer and takes lesser time compared to ACE. So these are the domains that we assess. And I'm sure many of you have come across MOCA and attention, language, abstraction, delayed recall, and orientation orientation are the ones that we test. The cue-induced recall is also there, and the frontal executive functions are also tested. The trail-making test is a test for both visuospatial as well as processing speed, and we also have a clock drawing test here. However, this is a very simple scoring system of 3 points, not the ones which we discussed earlier. Coming to ACE, let's say it has been popularized exceedingly in the recent years. It's a little long, takes approximately 20-30 minutes. The cutoff scores, again, have been debated. 88 and 83 are the usual norms. Most commonly, 88 is the one that is taken, and it incorporates MMSE. So when it was revised, MMSE was replaced by HMSE for licensing issues. And ACE has different versions, has been validated in different Indian languages. It has different scores. So if you see memory and language have equal points, fluency has the least amount of points, attention has 18, and visuospatial has 16 points. So it comes to 100 points in total. Again, for the dearth of time, we'll not go too deep, but you will see here, that attention comes first, then we test memory, then we go for fluency, then again we test memory based on recall, then we test language. There are different aspects of language testing, including naming the familiar objects. The objects that you see here in the screen are again changed in the Indian version, especially making the animals, the sickle, the drums more culture friendly. And finally, we go on to test visuospatial and come back to testing memory again in the end. So the common norm is to take 88 as the cutoff. Now, all of these are indicators for you. If the person is having a score of 83, that doesn't immediately mean the person is having dementia. So I'll keep repeating this multiple times because this is something which we tend to do a lot of times in our busy clinic. Coming to the detailed NIMHANS neuropsychological battery, which was developed by Tripathi et al. It takes, of course, a long time. Often cooperation is an issue, but it's quite comprehensive. And in a subsequent study, Tripathi et al. Had again shown that if we have to differentiate between MCI and AD using this battery, the most sensitive test is word list delayed recall, followed by fluency, followed by story recall, followed by executive functions. So why this is important is later when I come to it, then you can actually select certain specific tests from a battery to do certain, in certain individuals whom you suspect, rather than doing the entire battery. Now that's the benefit. This is the, NIMHANS neuropsych battery. These are all the tests that are used. I'll not really be reading them out, but if you see, it has components of memory, it has components of visuospatial, it has executive functions, verbal fluency, delayed recall, registration, set shifting and response inhibition, Tower of Hanoi, which is, a variant of Tower of London test, attention, focal parietal signs documentation, and finally, the praxo, the perceptuomotor and the praxis functions of the brain using stick recall. The ADAS-COG, that is the Alzheimer's disease assessment scale subscale, is more important for drug trials. It's actually considered to be gold standard and recommended by many guidelines, including APA, for assessing the response to anti-dementia drugs. It is quite comprehensive, has 11 items, and usually recommended that you test every 3 months. And if there is a decrease of at least 2 to 3 points or at least 2 points, you consider increasing the dose of the anti-dementia drugs or initiating them. What are the associated assessments? We all know about the clinical dementia rating scale, which is used to assess the severity of dementia. And this needs a training. So all of you can actually Google clinical dementia scale, and you will be having a website where there is a free training available. You can undergo that, and it comes across different clinical scenarios. Each of these domains of memory, orientation, judgment, community affairs, hobbies, and personal care, each of these have certain specific questions which are to be asked. So if you actually remember the present state examination, which we use, it is like that. So each of them have very specific questions. And this is very basic scoring rules that, memory is considered to be the primary, and other 5 items are considered to be secondary. So if at least 3 secondary categories are having same score as memory, the CDR, the clinical dementia rating score, is equal to the score of memory. So let's say orientation, community affair, and home and hobbies have score of 2 and memory has score of 2. So the CDR is 2. There are 2 types of scoring this. One is a sum of boxes. So that is a sum of scores of each of the 6 boxes. But remember, that is not global CDR, or that is not clinical dementia rating score. So dementia rating score will be based on your clinical judgment. And these are certain very simple nitty-gritties. So instead of CDR equal to M, if there are 3 categories on one side and 2 on other, the score of CDR is equal to the score of majority of the secondary categories. This scoring has been formed by the same group who has created CDR, and it just has certain rules, very rule of thumb rules which you can apply without going into too much of complexities. If you don't want that hassle, there is an automatic algorithm online in the same website. If you enter the scores of all the 6 domains, it automatically generates a score, but it's always useful to be accustomed and familiar with the CDR because it is an extremely important scale. We know about the neuropsychiatric inventory, which is again a useful tool to assess BPSD. There is a caregiver distress, which is a 5-point scale, and each function has frequency is 4-point scale, that is 0 to 3, and severity is a 3-point scale, that is 1 to 3. So the total score is frequency into severity. So maximum score can be 4 into 3, 12. And the distress is rated separately. So if you see, the domains are delusions, hallucinations, agitation, depression or dysphoria, anxiety, apathy, irritability, euphoria, disinhibition, aberrant motor behavior, nighttime behavior, and appetite changes. Just to say, the 11 and 12, nighttime behavior and appetite changes have been added only lately. Initially, NPI only consisted of 10 items. It is extremely useful in frontal, type frontotemporal dementia, and also in persons who are having florid BPSD. Similar scale is Behave AD, which takes a little bit longer time. It has 2 domains, and it also has a global rating. Activities of daily living, many of you have used the EASY, which is validated in India, and the items are more significant in Indian context. It is answered usually by the caregiver. So these are the items. It is answered in yes or no, and if based on the question, yes or no gets a positive point. That is only if there is a deficit, the scoring will be 1. And a score of 3 or more is usually considered to be significant. This was again developed by Dr. Mathranath from the neurology team of NIMHANS. It's the only functional ability scale validated in Indian setting. And for all practical purposes, instrumental activities of daily living are perhaps more important because they are the ones which are detected early. The activities of daily living can persist for a longer time. So if you see shopping, meals, housekeeping, managing finance, shaving beard, entertainment, all these things have been modified based on Indian context and does give you two types of disability, either cognitive or physical, so if there is any restriction. Quickly cover the bedside assessments. So we know about the frontal assessment battery for the frontal lobe. Again, this is the total score is 18. And the tests that are commonly used are similarities that we also use in Mia Gross, lexical fluency, verbal fluency, letter fluency, motor series, that is the fist edge palm test, the go-no-go test, that is when I tap once, you tap once, and when I do not tap, you tap twice, that is conflicting instructions, which basically tests your inhibitory control. And finally, whether the person has any prehension behavior. All of these are frontal functions, which test the different aspects of frontal lobe, orbitofrontal, dorsolateral prefrontal cortex. So usually a score of 12 or more is set to differentiate between Alzheimer's and frontotemporal dementia. Parietal lobe, You know the functions of parietal lobe. Primarily, the dominant lobe are acalculia, agraphia, apraxia. Apraxia is of the right of right left orientation, and the problems in stroke can cause Gerstmann syndrome. So these, as I mentioned in the beginning, can be understood through clinical aspects. The interlocking fingers test is it's a very validated standard brief test. You tell the person to imitate the examiners these types of finger interlocking, and if the person is close but unable to do that, that signs left-sided. It's a dominant parietal lobe involvement. And these are the basic things: naming fingers, knowing left and right, reading. And then you can test for apraxia, similar familiar face recognition, matching objects, and finally copying. The different types of apraxia, I'll just tell you about the ideomotor and ideational. So if the person is not able to understand the sequence of tasks, you tell a person, how do you hammer a nail, or how do you blow off a candle? That problem is ideational. However, if the person does not even understand, how to do, but knows what, so you tell the person replies, but you ask the person to imitate or show something, not by doing it, just by telling it, the person cannot do. So that's ideomotor. And of course, limb kinetic can happen due to other type of lesions. Temporal lobe, we test for hearing, we see for personality change, and the word list that I mentioned, AVLT, that is also a temporal lobe test. And finally, music processing and face recognition also involves temporal lobe activities. The Wechsler's memory scale, the verbal memory subpart, can be used to test temporal lobe, and it has 5 index scores. The specific domains which are validated in India, so these are just domain-specific testing. The SERAD word list, the constructional praxis, the ones which are mentioned in red are actually part of that same Mary Ganguly study in Ballabgarh. Category fluency, the Wisconsin card sorting test, and Tower of Hanoi are validated, and also validated for older population. Just remember, we have this LASSI, the longitudinal aging study in India, the first ever largest study in the Indian context. And what LASSI and subsequently the ICMR toolbox for MCI showed us is that it is not always necessary to do the entire battery, but based on the population, the literacy education level, you can pick up certain specific tests and then conglomerate them together and then have an understanding. So what LASSI did to test cognitive screening was it took up certain tests based on memory, orientation, retrieval, arithmetic, executive functions, and formed a composite test. Even at our center in Apollo, we do not do all tests for everyone, because that saves time, that saves money, that saves human resources, and that also gives you a clinical understanding of what you need to do for whom. This is extremely important in primary care settings where you have a huge patient burden. This was recently published. I suggest all of you go through this paper, and this has been validated in 5 Indian languages, especially for MCI. This is another paper worth reading, in which people who have low levels of education, older adults especially, this systematic review throughout the world, all scales were taken, and it was found that the MMSE or HMSE, the MOCA, the Persian test of elderly for assessment of cognition, the 6-item screener, and memory alteration, which are again all versions of GP-COG and IQ code, have stood the test of time and are sensitive to lower levels of education. We have to remember this, especially in Islamic countries. What are the challenges? Copyright issues, of course, cultural and linguistic sensitivity. They may not be, validated in different settings. Human resources, always we do not have this extensive testing. General physicians and primary care form the core of our health team. So they need to be trained. Sometimes, even we perceive deficits in training, and in that context, sessions like this organized by Thursday Musings are incredibly useful to the presenter and as well as to people who listen. And, we often do not get a test which is quite comprehensive. And finally, again, if you suddenly put the test forward to somebody in a confrontational manner and the person has no idea that what is going to be done, Imagine someone who has always stayed in farms or has run a shop coming to you and suddenly seeing himself in the midst of 100 cards, games, copying figures, telling stories, remembering stories. So there automatically is a deep-seated anxiety which can bias your results. And I should tell you here that in Dr. Ganguly's study, she specifically mentioned that HMSE does not have norms or a cutoff. So even cognitively healthy older adults have scored as low as 18. And remember, 18 in MMSE is equivalent to mild dementia. So in Indian setting, if we tell somebody above 24 as normal and below 24 immediately as having cognitive deficits, we should take a step back and think that it is extremely gross, because we are only assessing a person based on the memory. So the gist of it will be, for routine clinical practice, clinical interview to assess deficits are the gold standard. Cognitive assessment scales are only for having a standard, but not to diagnose. Usually a clinical suspicion followed by a brief screener and detailed assessment is the protocol. Review should usually be after 6 months, and otherwise it will be too early to show a change. A tailored assessment is the best approach in a busy clinic, and ACE, MOCA, and HMSE and cognitive screening battery are commonly used. These are some very basic but very useful beats for bedside assessments, as well as cognitive testing in older adults. Gives a very bedside approach. And once again, thank you for this opportunity, and I hope this session was useful. I just end by this with what I mentioned in the beginning. If you do have an index of suspicion, please go ahead and have some test of cognition, unless it is too late. Thank you. Thanks once again for your patient listening. I'm sorry I've overshot the time by a little more than 5 minutes. Thank you.
Thank you, Dr. Banerjee. I think it was very, very, very exhaustive. And it's a mind-boggling. There are so many psychological assessment scales and all. But as you rightly said, you should know what are the domains that you need to assess. And the most important thing is that, of course, as you rightly said, what we need is predominantly a short screening test, maybe about 5 to 10 minutes, like your MMSE or whatever, MOCA, whatever you feel is the short studies and all these things. And then if the concerned elderly individual is screening and possibly the scores are a little low, then possibly we can use a test like CAMGOG or a CANTAB or a Niemann battery or ADAS, COG, and where you're precisely trying to find out the intensity and all these things. And as I've been mentioning earlier, it's always better to screen elderly at an earlier stage so that we don't miss, and then we don't have a burden of taking care of these elderly people. It's a very nice thing that you have said that about various like recent memory, remote memory, attention, concentration, language, praxis, and visual spatial. But all these things cannot be, but simply as like what I said, the mini cog, maybe the best one to assess, or MMSE deficits where there is there any concern like this one. And then I think it's wonderful and exhaustive. I know Dr. Sabi, whether there are any people who want to ask questions, is there anything in the chat box, or Topan Patti or Amrit or Alim Siddiq, because I'm the one person who should not be talking more, and people are, it's a very, 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 very important. You've done extremely well, Dr. Banerjee. Congratulations.
Thank you, sir.
Dr. Sabina, are there any chat box which you feel that you should?
I think I'll ask the moderators to take over for the chat box now. There's a few questions here.
Okay, thank you, ma'am. First of all, I think it was a very well polished, exhaustive, and very well covered lecture. Most of the things that are actually useful are being covered. So I think it will be a very important recording that we have of your lecture, Dr. Debanjan. So congrats on that. So Amrit, can we start the question answer?
Yeah. Start kar.
Debanjan, please tell me, suppose it was a long lecture. है ना? Suppose I'm sitting in my OPD. So what are the 5 or 10 points that I should definitely not miss?
Yeah. So, see, the first thing first would be that where on an average, I see 50 to 100 patients daily in whichever setting, and an older individual comes to meet me. The first thing is the context in which the presenting complaints, of course, why the person is coming to us. Whether the person has self-perceived memory deficits, or whether at any of the points that I mentioned, do you see the person, just observe him and see that whether if he's confused, whether the person is first delirious, not delirious. So that's sorted. Whether the person is under influence of any medications, fine. Once I have a clinical suspicion that, okay, this person may be having cognitive deficits for whichever reason it is. I can suspect depression, dementia, MCI, doesn't matter. But if I have that suspicion, one, I should not miss that in the first visit. That would be first thing. Second, if I see that the person is coming alone, I should involve the family members to get a triangulated corroboration that, okay, whether the thing is actually happening or not. Third, whether I'm able to rule out the other psychiatric disorders before I come to a closure that this is a neurocognitive disorder, whether I rule out infections, whether I rule out fatigue, and all the other things that I said when the person is coming to a chamber. Because commonly what we have seen is the exhaustion of travel can also lead to bias in cognitive testing. So finally, I now have come to the conclusion that, okay, I have an index of clinical suspicion that, okay, this person is having cognitive deficit. If I am able to allot 10 minutes, I'll be going ahead with HMSC. I'll be documenting the score. If I am not able to do that, I'll go ahead with a mini cog. At least see 3 things. 1, memory. 2, recall. And 3, ability to navigate. Why? Because these 3 things will impair him quite grossly. And these 3 are easily understandable. If I have more time, and if I have another unit, I will inform him that you need a detailed screening, and I'll be sending him for testing. If not, and if I suspect a depression or another, let's say a psychiatric diagnosis in him, I'll be treating him, recording his cognitive scores, and I'll be seeing him on follow-up again and repeating the same clinical assessments that I have done. On the other spectrum, if I suspect any frontal behavior, I'll be looking ahead with my other supplementing with other assessments. Now, the last thing would be that these are only clinical and cognitive assessments. I have to decide whether I need to supplement them with any lab testing or whether any imaging. That would be my final call.
Yeah.
Thank you so much, Amrit.
Yeah, one question that has come in the chat box, and the most practical issues which we have when we are assessing the cognitive function in the elderly is maybe hearing deficits and eyesights, and hearing deficits is a very, very common thing which we are seeing nowadays. We have 10 to 15 minutes in our clinical practice. You take 3 to 4 minutes to build the rapport, and then you are shouting at the top of your voice. You are shouting something. The attendant is hearing something. It's like the Chinese whisper. You are asking something, and the attendant is even telling the answer to the to the client. So how do we take care of these things?
Thank you, Amrit sir. I think I remember on a lighter note, I remember when I first went to NIMHANS in 2013, I didn't understand Kannada at all. So one of my patients in my second or third OPD was probably a clinical suspicion of dementia. So I ended up almost with Hindi, English with him for nearly 15 minutes. I documented, I took to my senior resident and I told, there is definitely something wrong with this individual. And finally, all that came out was that he didn't know any other language apart from Kannada. So I think these are issues which are very common. And that's why I mentioned that, again, there are certain things like, if somebody has come to you for the first time, there are certain guidelines which say that you do not test them at that point of time. You build a rapport, and this is very, very common in Western practice. You build a rapport first, then you schedule a session for testing. But for us, that is not possible. So I would suggest that let's correct 3-4 basic things. Is the person able to understand you? Is the person able to see? Is the person able to hear? And if that is fine, then you can at least first ask one or two very basic questions to understand the comprehension. If that goes right, you go ahead with whatever cognitive assessment you want. And actually, sir, like the ones which I mentioned in the beginning, the very common things about memory, language, executive functions, these are sometimes which, we actually end up assessing even when you are asking routine questions. So sometimes it is not even needed to go ahead with MMSE or GP-Cog. But all that I'm saying is we need to document that, because sometimes the clinician himself or herself will miss it in follow-up visits.
Thank you. Thank you.
Very good. Absolutely. There is a question on HMSE. Why is it called Hindi? And is it something related to standardization?
Yeah, it is Hindi because it was done in the language of Hindi in the Ballabgarh population of rural India. So it is near New Delhi. It's a village where the Indo-US study was conducted. And again, it has been done again, made in different other languages as well, but originally it was done in Hindi. Regarding standardization, yes, it was standardized by the same team as Dr. Mary Ganguly, but as I mentioned at the end of my presentation, that you cannot really hold a very strict cutoff. So you have to understand that, I strongly recommend all of you to actually go through Dr. Ganguly's original paper, because that's brilliant on a take on how a cognitive test is really formed, and the difficulties, the challenges that they faced in the Ballabgarh population. That when they brought and they told them to copy, everybody was holding the pen and staring at their face. So, and even different talks of Dr. Ganguly, which are recorded, also mention about the challenges. I think this becomes very important for many of us to do community work, because, many of these tests of language and executive functions are very foreign to people from rural settings. And they can give very biased responses if they are not prepared.
Okay, there's a question by Rahul. How to factor out IQ while using a screening tool?
Yeah, that is the primer. So if you are, let's say, testing somebody who has a history of IDD, now you will get some by the history, right? So the person, by default, when we call dementia or when we call MCI, when we call cognitive decline, there is a component of decline. So there is a decline from the baseline. That is not to mean that a person with IDD may not have dementia. But through history, you will understand that, okay, these are the activities the person was able to do. If the person was not able to do those activities even from before, what has declined? So that will be more of clinical at that time, because then if you apply a cognitive test, both education and prior IQ will influence your responses. So that time, clinical understanding and history becomes extremely important.
Amrit.
There's another interesting question. Like, you were talking about different lobes, different tests, and I think stubborn and black has been a very, very, when I had my first case conference, I had a case of Rasmussen's encephalitis, a very, very tough case. And that is where I actually learned stubborn black, how to apply stubborn black. And for me, that is the golden standard to when it comes to assessing, neurocognitive deficits in terms of how. I think that's it. That's a little bit, if you practice it frequently, it's a very, very easier tool. And MMSE, as you talked about, you have to take permission if you want to publish. So there's a question here. Do you have scales to differentiate different types of dementia in clinical settings? So which is the best scales to use?
Yeah, I think that's a very relevant and useful question. Like one of the scales which I can tell you is the FAB, the Frontal Assessment Battery. So it has been specifically studied to differentiate AD and FTD. And a score of 12 is the cutoff, which almost has a sensitivity of 88%. The HMSE and the MMSE or the GP-Cog are, of course, not sensitive enough because they are heavily biased with memory. What I would suggest is that when you are doing ACE or when you are doing MOCA, always remember and look at the individual responses rather than the global score. If somebody tells you a score of 80 on ACE, what do I infer? I infer, okay, the person is having cognitive deficits. If somebody tells me a score on memory is high, score on visuospatial ability is high, score on language and frontal is low, I know that I am looking towards somebody with frontal and executive functions, dysfunction. Now, again, scales are not meant to diagnose. So you will be diagnosing based on the clinical criteria, but the individual domains or the Lober test that you are doing, the results which come up, that will show you that which are the areas predominantly affected and which are the, what based on those domains, what dementia you are likely suspecting. Let's say an example, you test a person different times of the day, different days, and the response is different. There is a high likelihood either this person is recovering from delirium or the person is having DLBD. However, there is a scale. Again, it's very recently validated in only the US settings. It specifically tests cognition in Parkinson's. It's by Rosaville et al. And that is one of the things which you can use in Parkinson's. But otherwise, these scales can be used in any dementia.
Thank you. Another question I want to ask, Alim, if you permit me. We get a lot of patients who come to us, relatives coming to us. They tell us that, sir, give us a certificate that my father is suffering from dementia. I cannot take out money from the bank. No. When, how, what is the assessment that needs to be done? Because we can't shy away from our responsibilities, telling that I don't give certificates, you come again. So is there any definitive plan or any, as we call SOP, to give such certificate? Based on these calculations, based on these observations, I gave this. So
I think that's a very, very useful question, sir. In fact, one of the very reasons why the scales have been so popular is for the medical legal need. Now, again, to the best of my knowledge, there doesn't exist a standard SOP for that. But I can tell you what we used to follow in NIMHANS and what I've heard from my fellow colleagues in KGMC. So it all depends on what certificate and in what context is it being asked. If the person is asking a medical unfit certificate, my clinical understanding, assessment, and a screener is good enough. But most of the times, a person will be coming asking that the bank has told me to give a certificate because the finances need to be changed, or I need to take other responsibilities, or let's say from the lawyer, somebody can contest that my father or mother is not in the proper state of mind, and thus I need a certificate to prove or disprove that the person has dementia. In that case, none of the screeners are enough. We have to have a clinical suspicion. We have to document our diagnosis by any of the standard diagnostic codes, be it ICD or DSM, and we have to have a proper standard battery applied. That has to be validated in India, of course. So NMBE is the most likely option, or you can even go for Cantab or Cambridge one.
So ultimately,
neurologist also attached with the certificate.
Yeah, there was a question. Yeah, there was a question by Dr. Lal, whether the neurologist or psychiatrist should certify it.
Both can. It all depends on whom you have been following up, and so like sometimes people come to us. So let's say someone has been following up in neurology clinic for 2 years, and they have referred to us for management of BPSD. So in that case, it is better that the primary doctor who has seen them from the beginning or who has done the evaluation of dementia give the certificate. So if whichever team has actually mentioned and documented that for the first time that the person is having cognitive deficits or has suspected dementia, that clinician or that team needs to give the certificate.
Okay. Amrit, I think Gautam Da is there. Gautam Da.
Yes. Fantastic, Debanjan, Dr. Debanjan Banerjee. It is really good that, and we are lucky to have him in Calcutta. In fact, geriatric care will be much more better. I hope that his treatment, and we are always there, and we are definitely, there is no age for learning, and we have learned so much today. It is an excellent presentation. And thank you, Dr. Panpati, Dada, and also my two younger brothers, Dr. Amrit and Ali, for organizing the best webinar in the country. because it is really going very, very well. So proud of you.
Over the chairpersons for the
Thank
final
you.
comments.
I think Paresh sir wants to make a comment.
Yes, sir, is there? Yes. Sir.
Hello,
Paresh?
I'm audible.
Yes, sir.
Acha, when we come to know from the patient and the relatives that he had, so do you think should go always for test or any batteries or any scale, or we can straightway start treatment at that time? Right, this is my question.
Okay, so thank
Hello.
you, sir. Your voice was slightly breaking. So if I understand it correctly, you were asking that if the family reports of any cognitive decline, whether we always need to do any standard test or we can start treatment otherwise, right?
Yes, yes.
Yeah. So if either the patient or the family comes with a complaint, under no guideline it is mentioned that a cognitive testing is mandatory. A clinical assessment is good enough for you to take a decision of starting whichever medicines you want. However, if you strictly go by guidelines, then both the NICE guidelines and the APA guidelines and also the IPS guidelines mention that you need to have some sort of baseline cognitive assessment before you start the anti-dementia drugs so that you know what you are dealing with and what has improved. Of course, you can do that clinically, but many times because the legal and financial complexities can arise in an individual with neurocognitive disorder, it is always good to have some sort of structured documentation.
Debanjan, if I keep on continuing testing Amrit and suppose his cognition falls, so after how long this cognition will start falling?
So firstly, hope not so, but yeah, so see, it depends as to what we are looking at. Now, follow-up time is typically between 3 to 6 months. But again, as I said, sir, that let's say somebody has come and I suspect that, okay, this is a pseudo dementia. The person is having well enough signs of depression. So then I may just do a HMSC, document the findings. And then later when I treat the person with an antidepressant trial, let's say 4 to 6 weeks down the line, when the person comes back again to me, I can still do a repeat testing. But the good thing in these cases are that often it's clinically so obvious that you really don't need to go ahead with any screener. But if you are going for a neurocognitive disorders or if it is MCI, 6 months is the usual norm because before that, ideally nothing changes. And the NICE guidelines also recommend 6 months.
One add-on question just came in the chat box. What is the role of neuroimaging? How does it supplement or how important?
So that's a separate discussion altogether.
Yeah.
But I think just to tell you very briefly, a tailored neuroimaging is very important. So like I said, it is not mandatory to get every person to have an MRI. That is the first thing. So a CT scan suffices well enough. But again, any guideline you look at, if you are suspecting a person to be suffering from neurocognitive disorder, at least some form, and this is the word used, some form of imaging is a must to start with. But again, that depends on your clinical take. Of course, whichever lobar problems you are suspecting, whether you do a structural or functional MRI, you can actually correlate that clinically because ultimately you are not treating a cognitive assessment scale, you are not treating an image, you are treating an individual.
Thank you. Amrit, should we go over to chairpersons now?
Debanjan
Yes,
has been
yes.
speaking non-stop for the last 1.5 hours.
Yeah, Debanjan saved you. Chairpersons and then Tufan Pati sir.
Yeah,
Chairperson.
the only one thing is that recently our college lecturer, she had come and said that her father had willed the property to her granddaughter. And then whereas the son, other that he has gone to the court saying that the person has been diagnosed with dementia in 2014 and he had executed the will in 2018. So both the lawyers are arguing he would have had memory problem, but he had an executive function. He knew what he was writing. But then the other lawyer is telling he had got dementia in 2014, how he can execute a will in 2018. It's really sometimes very difficult to because you do not know, you are in 2022 and you do not know whether at the time of 2018 he was sure what he was doing. Sometimes very extremely difficult in the. What do you think, Banerjee? What should be happen here?
Yeah, so, sir, I think thanks for bringing that out, because this is something which we commonly face, especially because, dementia happens so much on a continuum. So as I said, it doesn't really happen like one fine day in the morning, nobody gets diagnosed. And especially in institutes, in practice, different people may see the person, different clinicians may see the person at different stages of cognitive decline. So it is extremely important, if we are suspecting or if we know that a case can have the medical legal significance, it is very important that whatever we document, and our standard training was that it's always in these cases good to document lesser than to document more. But maybe you need to have a record as to what you are giving the patient, because let's say you are doing a HMSC, and even certain questions have come like why the full form of the test has not been documented, or why MMSE was not done, or why you haven't tested this particular lobe of the brain, or why haven't you done neuroimaging. The best way will be that perhaps something which we miss is to find out, because in an older individual there may be 4 different clinicians seeing the person: a neurologist, a psychiatrist, a medicine person, a rheumatologist, and things like that. So if we can actually have, let's say, a very brief 5 minutes chat with all the clinicians involved, it is always better to be on the same page, because certain cases can be potentially trouble.
Okay, one small thing I like to ask you: has there been any studies where people have been administered monoclonal antibodies and then said that the memory decline has improved, or deterioration has been stopped? Is there any particular, because people talk about monoclonal antibodies now and memory?
Sir, again, I may miss it very much as well, but to the best of my knowledge, when I was just reading up for this, I think there has been a study from a Spanish group very recently in late 2021. I'll try and share the paper if possible, who has actually seen the effect of antibody cocktail on individuals with post-COVID sequelae. And for them, they have seen that there has been a significant improvement, but then the sample size has been really pretty small. It's only around 50. And again, it all depends on whether, if we are looking at post-COVID sequelae, then whether it's a direct neurotoxic effects of the virus or whether it's a worsening of a pre-existing dementia. So those factors need to be kept into account.
Dr. Sabina, and then I think
Yeah, just thanks a lot, Dr. Banerjee. Very basic, simple, straightforward points, practical use of scales. I didn't know there were so many scales. And for us, at least, to start to think about dementia, how we document it, what are the possible scales we all can use in a busy practice, as you mentioned. So, and as our population grows older, I think it's in our faces. When I came back to India, I had no plans to practice geriatrics. But I think that's a third of my practice is geriatrics now. So I think it's probably everyone's story. So thank you very much for bringing out this extremely important topic and making it simple for all of us to understand. Over to you, moderators.
Tufan sir.
Okay, thank you. I have a note of appreciation, a comment, and a question. Debanjan, your presentation, your erudite presentation has been overwhelming. So much overwhelming that I could not take up all the tests. I shall have to go to the YouTube channel and slowly go through that. And if any doubt, I shall ask you. And I think it could have been with many people of my status to take up so many scales and comprehend and gulp them now. But your presentation has been very nice and it shows many more avenues. I appreciate. My comment will be related to the question about certificates, because I have been dealing with that a lot when I was working with Dr. Bimbadhar Das in Mental Health Institute, which is the only referral center in the state. Maybe every week we had to deal with 10 or 12 medical legal cases like this. So my first take is that when I have to certify a patient I am treating, I have to give the certificate and the basis of the records that is available with me or in earlier days with the patient. And in a clean way, it is explanation of what we have recorded. Interpretation goes always to the judiciary. We should not be judgment. Number one. Number two, people do not try to exploit only for the purpose of civil responsibility. There are many cases I know I can name where criminal responsibility has been the concern. People want to get a certificate and somehow twist and get over the allegations. And third important aspect is, when do you give the certificate? We have to give a certificate examination report where we see it. I see today patient, I make all the testings, make a clinical recording, I keep the patient, observe for some days, and give that on the basis of these observations, the present mental status is suggestive of Alzheimer's disease. Okay. That no way establishes that if this person has got into a deed 2 years ago, it was wrong. I have never attested that. So our language should be protective, that my examination today on this date or over this period, on the basis of this I am making this opinion. There cannot be way that we have to be eager to give a certificate. Next thing, another certificate which we are bound to give is when the court advises. We have not dealt. You are the chief of the ultimate referral hospital in a place, and the court asks. Then you can also ask the court to give you that environment, that time, and that records which is required to get the certificates. And the more critically, more intelligently we record the things, we are safer. Because when there are two parties, one of them will be against us. Because we are doing the service. This is my comment. My question is, two questions. Just like MMSC, we had HMSC for the people who follow Hindi. Is it required to have a TMSC for the people who follow Telugu? OMSC for the people who follow Odia? Because we cannot claim. Those who follow Hindi, they will follow Telugu and Odia with equal competence. And in a diverse country like India, is it required to have validations in so many languages? And second question is that I start with what Dr. Ramanathan told, that the main people who, if trained, will be very much helpful are the primary practitioners, primary level physicians, and how much we can train them from the vast basket that has been presented by Debanjan Banerjee. You give it to any physician group, they will just sleep after half an hour. So how much you can train them, what should be their take-home message? If I invite Dr. Debanjan Banerjee to a seminar workshop for those people, how much you have to convey them? To me, it appears it is also a challenge because they have got very little time. They see pregnant ladies. Simultaneously, they see a case of intersubstantiation. And then we claim that you have to see every old patient and screen them if they have dementia. Or if they are compliant, how they are going to do that. These two are my questions. I have praised your presentation and given my statement about certificates. You can give brief remarks because I know you are tired.
Yeah, thank you, sir. To answer your first question, actually the HMSC has been validated in different other languages, almost 7 other languages. But again, let's say the languages in which it hasn't been validated. Yes, I think that often a literary translation of words does not work, especially when you are telling a story or when you are telling, when you are telling a person to follow me, follow my instructions. It does have a lot of linguistic variations. So, unless it is really validated in specific languages, It may not be 100% accurate, but yes, to some extent it will be possible. To answer your second question, sir, again, I think the reason why I tried to cover maximum number of scales in this presentation was that I thought, this will be recorded. So this may be a useful exercise for, many postgraduate students so that they can just have a glimpse. Of
For
course,
all
all
of
the
us,
scales
for
are
all
it's
of us.
impossible to
I
cover
shall
in
go
an
through the
art
recording
lecture.
again.
And also based on the target audience. But as you told, very, very importantly, that if we really need to train the primary care physicians, and if I am to train them or if I have to take a workshop for them, first, I would limit myself to either 2 or maximum 3 skills. So I would take Minicog, I would take HMSC, and I would take ACE. And what I would be focusing on more are 3 things. 1, whom to test for, how to test for, specifically if the questions that needs to be asked, how you need to ask them, taking any one particular skill, because how we ask and how we note down make a lot of differences. And third, what sense to make out of the findings. So rather than telling them about many skills, I think it is important to tell them the clinical context and help them familiarize with 1 or 2 skills which they can quickly use in their busy practice.
Thank you. Thank you very much.
Amrit.
Over to Amrit.
So on behalf of the IPS Odisha State Branch, I would give the formal thank you. Everybody has spoken. They've been singing accolades for Dr. Debanjan, and I found it was simply too good. It's a very vast, very exhaustive thing, and these skills are not so easy. To master one skill, you need maybe 6 months, 1 year of constant practice. It's not as to make it simple, to make it into a 15-minute thing or a 10-minute assessment. You need to work on it for maybe 2 to 3 years. It's not that Dr. Debanjan spoke, I heard it in Facebook and I get on track. You have to practice, practice, practice. And I think that's the only way you can know what questions to ask to whom. If there is an, you need to assess that, because you don't have, even the clients don't have that much time as we think they have. So somewhere we have to practice to get the best out of whatever we have learned. And I think Dr. Debanjan has been exhaustive, but maybe one day we'll call him to speak on one scale only. And that will be a tougher challenge than giving an overall talk about a lot of things. So Dr. Debanjan, be prepared for another call. We will have you another. Dr. Ramanathan, sir, you have been wonderful. And your contributions, your inputs have really opened up the whole debate and led to the presentation. Dr. Sabina Rao intelligently played the second fiddle. She told, no, let me just listen and thank you all of you for your wonderful contributions. We'd love to have you again. Dr. Tofan sir was adequately prepared for this talk. I think he had his questions, he had his answers, and he had his queries. Thank you, Ali.
These such activities prevent us. These
I was
activities
inspired.
from
I was
developing
inspired by
dementia.
Debanjan. And I have a comment for
No,
Gautam.
thank you for us, isn't it, Ali?
Dr. Gautam Saha, IPP, I have a comment for you. You expect some help from Dr. Debanjan Banerjee because he is now set clinical career. I can assure you that you are not going to get that help because you are not going to get old.
Yes.
You are not going to get that help.
And I wanted to answer one question Dr. Ali asked, that when he's assessing me for cognitive deficit, he finds deficits. I think then the challenge will be whether the person who's taking the test is adequately tested or not. So like Debanjan was talking about Canada, somebody knows Canada and he was asking in Hindi. So also maybe Alim would have to find the right type of questions to ask to me to find cognitive deficits in me. So, we are sometimes challenged to find out cognitive deficits. Thank you, everybody. Thank you to our, all our people who follow us. We had again more than 200 people who had logged in, 250 or 260, 190 peak. And that's a wonderful number. When everything is open, people are walking in, having
Thanks a
meetings.
lot. Maybe Debanjan, I can ask you to conduct a workshop for some GPs.
Yeah, thank you, sir. I think that will really be, a good opportunity for all of us.
And that will be, I will be attending that. I want to know how much you can train. Then we will be also taking up that work. We want to see what you are going to tell. How much help?
So, sir, we have actually conducted training for GPs back there in Bangalore, and that time we solely used to focus only on one scale and training. So that was more of very hands-on, practical, and somebody used to actually we used to bring patients, individuals who are actually having problems. And for them, I think it's more of when to administer and what to make out of it, rather than a number of scales or more of theoretical stuff.
So enough for evening. Thank you so much.
Right
Thank you
time
for
to
that.
tell good night. It is
Good night.
12 minutes to 10.
Bye-bye.
Thank
Good
you. Bye-bye.
Thank you again. Thank you.
Good night, everyone. Bye bye.
Good night, Dr.
Thank you.
Satyanathan. Thanks for coming in the first request.
Thank you, sir.
Thanks. Sabina was very busy. She could not talk to me for even one word. Yes, sir, I will come. Over.
Okay.
Well, thanks for coming.
Bye-bye.
I had already primed her, sir.
Yeah. He gave me a list of instructions on what to say. So,
She was already
Thank
informed.
you, Dr. Alim, Dr. Topi.
Thank you, sir. Thank you so much. You are wonderful.
Thank you all. Bye-bye.
Thank
Thank you, sir. Bye.
thank
Good
you.
night.
Thank
Sir,
you,
can we
Dr.
close the
Balaji.
meeting now?
Shreya, you can push all of us out and close the meeting.